meeting to order.
Have you seen it? It's like a little lawnmower. It's like they're doing it. They're looking at us.
Counselor Deere, would you like to lead us in invocation, please?
All right. Lord, thank you for letting everybody gather today as we get together again in protection of our tribe as we go through these meetings today. Amen.
Okay, roll call.
Mary Baker Shaw.
Bonnie.
I think I can go as long as I can hear.
Chris Boston.
Here.
Harley Buzzer.
I said, do it as long as I can.
Julia Coates. Here. Sean Christian. Joe Deere.
Fine.
Stan Duncan. Rick Jordan. Daryl Legg.
Here.
Wes Snowfire.
Honey.
Dora Petskowski.
Here. This is
Mike Jimbaugh.
Here.
everything that's highlighted and added into your name is what's getting reimbursed.
Denise Taylor. Here. Victoria Esquez.
Thank you.
I was here, I didn't hear my name.
Victoria answered.
Okay, thank you.
What about me?
Okay, everybody had a chance to look at the minutes?
Move for approval?
Second.
All those in favor, say aye. Aye. Okay, reports. Claremore Service Unit. Is George with us today?
It's probably virtual. The screen is not down.
Is he virtual today?
I sent him a link this morning.
Let's see if we're going I think isn't that Dr. Jones?
Looks like George hasn't been able to connect yet, ma'am.
Okay, thank you. Well, then we'll go ahead with Dr. Jones. Good morning, Dr. Jones. Can you hear us okay? Dr. Jones, are you able to hear us?
It's kind of cutting in and out, but I can hear you pretty well.
Okay, great. Well,
Can
since
you guys hear me okay?
yeah, since Mr. Valur isn't here, would you like to start with the reports, please?
Sure. All right. So you have your report in your packet, and I just want to kind of walk through that report just a little bit, and before I get to some of the other items I want to report on. So first thing on the second page of your report there, you'll see surgical procedures, and I know I've got a few questions from some of you about surgery, so I want to highlight that we are delaying elective surgeries currently. So that is due to, we have a group that of physicians and personnel that we put together to look at each week. They meet every Thursday to look at the following, look at the trends of what's going on with our bed status, with our staffing, and to decide whether we will delay another week. So we're looking at that. It's a moving target that we're looking at 1 week at a time, and currently we have delayed elective surgeries for next week. Today they'll be looking at the following week, so we have plenty of time to let our patients know. One of the things that we're watching closely is our bed availability. As you know, with the COVID pandemic, we've had a little spike recently, and with that comes bed capacity increases. So we want to make sure that we're not overloading our hospital with and reducing our ability to treat those patients that come in through our emergency services. So that's something that we're watching closely, and just want to make sure that everybody's aware that that's an ongoing process. And Dr. Montgomery's leads that meeting, and he lets me know every week on whether or not we're going to delay one more week or not, and then we get a hold of our patients and let them know so that no one's left out of the loop or shows up and doesn't get the service they intended to get. So the next thing is, on the next page, you'll see our provider recruitment. We're down, consistently staying down at this report, 1.7%. Our contract health expenditures are listed there, and then the approval rate, 97.2%. In spite of our workforce being at a lower capacity with all the people that we've got home and trying to keep safe, we've still been able to keep up with all of our referrals and keep that approval rate at a high mark. The next thing, the next page, you'll see the patient visits and revenue. The only thing that I want to highlight, of course, we all know the patient visits have been down as we were closed and started to look at the model that we're using to deliver care. But if you'll notice on the far right-hand side of that, you'll see WWH is a lot lower, and then you have CNOC right beside it, which is a lot higher. So what that's reflective of is those services that moved out of the hospital over into the outpatient center, and those are being reflected in two different columns now, so that looks a little skewed there. And as you can see, our third-party revenue is down, of course, because of our business being down, so that all correlates. We go to the next page. It's pretty self-explanatory on left without being seen, some of the graphics that we continually provide for you guys. And then on the last page, we have prescriptions filled by site, and there's one that sticks out here that's incorrectly reported, and that's the Salisaw. Somehow that got inverted, so the 5936 should be on top, and the 7160 should be on the bottom. So when that graphic was put together, we got an inverse of how that should be put. So as you can see, I know Harley was, Councilor Buzzard had mentioned a couple of times that we were out of, and Jay, we had an issue where we had more new than refilled, and it was a process that we needed to correct on how the orders were being put in, and once we got that corrected, now everything's in the correct ratio. All right, and any questions on that report?
Anyone have any questions? Councilor Dobbins.
Yes, Dr. Jones, have we restarted routine care and dental?
Yes, and if you don't mind, can I go ahead and I'll finish this one, and then we'll go back and because I'm going to highlight that in some of my report, and then I'll come back and answer a question on that if there's another one. If you don't mind, Madam Chair, is that okay?
That's fine. Thank you, Dr. Jones.
Okay. So some of the things I wanted to report to you, the refill center has completed their move. We did that with very little to no impact on our patients. We were able to allocate all those services out to the clinics, and they took care of the refill services until the refill center came back up online. So that move is complete, and the last clinic came back online yesterday. So all clinics are back up online with the refill center, and everything is coming out of the newly relocated refill center. I didn't get any calls from any of you, so I'm assuming that everything went very well. We had no patient complaints on that, so our planning paid off, and everything went very smoothly. The patient portal, we're seeing more patients using that than ever before, so that's a good thing. That's a service out there that allows patients to get right into their chart. We are getting a lot of calls on some technical issues with it, and it's more so on the usage. So we're starting some educational videos that we'll be putting out to help those most frequently asked questions and help patients get through that a little easier, rather than having to sit on a technical support line and ask a question that is more of a user error than just a technical error. Public health and nursing continue to stay very busy with contact tracing and case monitoring. Those numbers have gone up recently, and we are continuing to put resources toward that to help us mitigate the spread of COVID-19. We're working to continue opening up our testing. Those supply lines are still not completely opened up to where we can purchase testing kits from the vendors yet. They're still coming through FEMA and IHS, and we are still getting our allocations and working to make sure our allocations are at the maximum that they can be for the size of our user population. So that's something that the ongoing issue that we work on routinely, just almost every day. We are anticipating that those vendors will open up the supply lines to allow us to purchase directly within the next couple of weeks. And we already have our contracts in place and our POs in place, so we're ready to go. I think we're first in line in our state with our main vendor, and then we're second in line in our region. So we're ready to move forward as soon as that ability is out there for us. We are working on an MOU with the state to participate in an antibody surveillance program. So as soon as that rolls out, we'll be starting to work to do antibody testing and report that. So that's going to be something that the state is leading on right now, and we haven't been participating in antibody testing up to this point of the lack of clinical value to it. But this is going to be more of a surveillance program to see who has it and who doesn't and record those. So, but clinically, there's no significance to it for us when treating patients because there's no evidence to say if you have the antibody that you are immune. So until that evidence comes out or the research comes out that tells us any information on that, it's not a clinically diagnostic test. It's more of a surveillance to retroactively see who has it after they've been infected. Construction on OSU project is back on track, and this last meeting, no delays. We're anticipating to stay on track to have that building up and running on time. Construction at the Stillwell project is up and going, and this meeting they reported no delays in getting equipment or supplies. So we're anticipating that they are tracking on time currently. We're moving forward with our stroke certification. We get our first survey in October to get us certified to be a stroke certified hospital. That's something that, again, is outside of COVID that we're continually working on all these other projects too. And I want to give kudos to our team because even with all the distractions and the workforce being a little bit depleted, we're still able to keep moving these projects forward and keep them on track to get those certifications. And then also we're working every day to transition into our new healthcare model, which will be a combination of telemed and face-to-face visits. We're looking for opportunities that will be the best for our patients. We've tried a couple of different formats and how our patients can platforms that our patients can use to talk to us. But we're finding that there's some big challenges out there with accessibility through either broadband or through the phone system or whatever it is that patient has. So we're always looking at different platforms that we can utilize to make that easier for our patients. And that's an ongoing process. It's kind of a trial and error. Everybody's trying to find what best works for their patient population. So with that, that's about, in a nutshell, a lot of the things that are going on. There's much, much more going on. But those are the things that I wanted to highlight today.
Well, thank you for that. Any questions from council?
Oh, and the question on dental. Let me answer that question real quick. So our dental clinics are back up to currently at 75% of their capacity. We anticipate by October 1st we'll be back up to 100%. So we're slowly moving into this phase of learning the new what our efficiencies are with all the new PPE guidelines and creating aerosols and how we can keep our patients and our staff safe. So we started out at 50%. We've moved up to 75% now. And as we get more efficient and keep doing our checks and balances to make sure we're keeping everybody safe as we can, then we're anticipating by October 1st to be at 100%.
Very good. Councilor Dobbins, did you have any other questions? Okay, Councilor Buzzard?
Yes. I hope he can understand me because I couldn't hardly hear Dr. Jones, so hopefully he can. Last month we'd ask you, or I'd ask you for some numbers on children getting the COVID-19. Did you get those numbers for us?
Yes, let me pull those back up. I reported them right after you'd asked me at the end of that meeting for that time. Let me pull up the most current ones, and I can get you that real quick. While I'm looking for that, is there any other questions?
Yes, I just want to comment on, I've had several people to comment on the late appointments at night. They like them those people that work, they can go down and get CAT scan, whatever they're scheduled to, so they like those lifetime appointments. So that's a plus for us here at the clinic, and they're wanting to leave them on, so that's something we might want to consider. And I just have a couple more about, I guess, I had been there at the new clinic here at Hastings, and we had talked about it, and I know that you'd had input on getting those veteran signs up and then expected mother signs up at our clinics. But I think they overlooked the new clinic up there. There's probably 60 or 70 handicapped parking spots, which is good. We need those. There's motorcycle parking, but there's nothing for the veterans or expectant mothers. I had a mother that was parked probably as far back in the parking lot as you could get. So if you don't mind, take a look at that. I'm not sure that's in your realm, but I'm sure that you can get that taken care of there at the new clinic. The other one is, and I'm not sure this is in your realm, maybe in somebody else's thing, but just the view there at the new clinic. If you drive up, there's that orange plastic parking, not parking, fencing along that bluff or the drop off there. Is there some way that we could get funds to put a nice looking barrier up there, such as plastic fencing or something like that? It looks a little tacky with having that orange plastic barrier up there. So, and that may be in the future that you're going to do anyway, but I just want to bring that up. But back again, the late night appointments, I've had several calls about it. They like them, so we might want to consider something along that line. I think right now it's for MRIs and stuff like that, probably get caught up, but that's good. So anyway, I appreciate your time, Dr. Jones.
So let me address those one at a time. So the parking, I'm not sure on, but I can check on that. Fence, that was part of the construction fund, and it has been bid out. The orange temporary fence that has already been bid out. I think we're waiting, accepting what bid is going to get those and get that taken care of. It's going to be a fence that meets all the safety standards and everything of that nature. As far as the late night appointments, yes, we put that in place to catch up on the backlog of imaging. So the challenge is what we can do in a facility with the appropriate staffing, and currently we're at a good staffing ratio that's allowed us to do that. However, that can change according to how things go from the COVID testing. If we have to quarantine somebody, or if people are sent home for that reason, we may have to pull back on that. But that's right now we do have those extended hours to catch up on our backlog. As far as your testing question, can you repeat it? Was that from 0 to 4? Is that what you were asking?
Say that again.
On the testing question, were you wanting to know the percentage from 0 to 4 years old? Is that what you were asking?
Well, I'd rather have the numbers instead of the percentage.
For the number
zero.
What's the exact question? I've got the testing pulled up, so.
Okay.
What were you wanting to know?
From the age of 5 to 0 to 5, or 1 to 5.
Okay, 0 to 4, we've had 29 cases. That's 2.2%. And then it breaks down to 5 to 17. And 5 to 17, we've had 140 cases, which is 10.8%.
Okay, that's 29. Do you have an area where those 29 come from, or it's probably impossible to do that, isn't it?
Yeah, I don't have that. It doesn't break it down that granular.
Okay. Okay. Well, that's what I want to hear. Thank you. If you don't mind checking on those signs we talked about, if you would.
Will do.
Okay. Thanks.
Okay, anybody else with questions? Councilor Nuffire.
Where are, one thing that I guess was a concern of mine, I know there's been a few primary care physicians that have gotten patients of theirs called me, and a couple of surgeons, I think, that we're not renewing their contracts on. I know that those come up from time to time. I just am a little concerned about not renewing contracts of doctors during a pandemic. I feel like that may be something that we'd want to try to see how we could keep every doctor on staff until we're through with this?
Well, I can't speak to specifics on employment matters,
Right.
of course, but I can tell you that last year when we revamped our contracts for all of our providers, we set certain expectations in those contracts. We have relaxed those expectations tremendously. Dr. Montgomery and I made decisions based on circumstances that were extenuating and beyond the control of providers to relax those expectations considerably. With that being said, there were certain areas that our medical staff felt like changes needed to occur, and so I have to support those changes when the medical staff makes decisions that they feel like is in the best interest of Cherokee Nation or in our patients. And so from that standpoint, we look at those every year, and those are some of the decisions that are made. As a routine, there's no bad references or anything like that comes along with that. It's just a decision that's made that it's in Cherokee Nation and their patients' best interest to move forward in a different direction. We have made sure that our patients don't see a fall off in anything that when we decide to make it move in a certain direction, that our patients are taken care of and there's no one left without care. This point in time during this pandemic, the one thing that you probably should be aware of, and that everyone should be aware of, is we are a unique health system that has been able to sustain this in a very unique way because of the financial planning that's gone on with our tribe for years and with the CARES Act money. Other health systems are not in the same shape we are. There are a tremendous amount of people reaching out to us right now looking for work. There's a lot of health systems that have furloughed and shut down hospitals that have put a lot of providers out of work. So this is an opportunity, we see this as an opportunity to look at where we can expand services, look at where we can make it the biggest impact for our patients, and so we're going to take advantage of this opportunity because of the financial situation we're in, and move forward with providing the best care that we can for our patients.
So what's our approximate time of looking to be able to fill those positions?
That is up to, we have a process that we go through, and as that process, moves forward, we have people in the pipeline that have reached out to us. We have people that are already in the recruitment phases, and so we also have the ability to reach out to temporary services if we need to fill a gap. So we have, again, we have everything paid and covered to the best of our ability, and some of those opportunities that we have will occur very quickly, and some of those opportunities we're going to be very selective and get the best possible person that fills the need for that community and meets the need for that specific population. Every clinic has a unique population. They may have different diagnoses that are unique to that area that we need to really focus on, and we look at this as an opportunity to broaden our services and increase our access.
Yeah, definitely need to increase the access because I feel like more doctors will help increase that access instead of creating a backlog when we're not getting those doctors to renew contracts. Does and our emergency rooms, I guess, how many doctors do we have with our emergency team right now? I think that I don't know have we expanded that since COVID, or are we still operating with the same emergency room staff?
Well, our staffing goes up and down depending on what's available to us, and with all the people who have been met the certain requirements to be able to work, not be in the workforce or being paid to stay home and stay safe. As far as vacancies, I'm not aware of any vacancies in the emergency area or the urgent care right now. Like I said, our vacancy report is down to 1.7%. So when we look across the board, we don't have any vacancies in that department. And we are looking at trying to make some modifications to that department and separate, do some things to make it a little bit easier for patients to transition either into the ER or into urgent care instead of having those combined services. But we haven't got there yet. And as we do that, we will probably be expanding both of those departments to meet needs and hopefully extend some hours to make it a little easier for working parents that need to just go to urgent care that don't necessarily need to go to the ER to be able to access those needs. So this next year, the next budget, we'll look at what we can do to expand those things and hopefully expand our providers.
Okay. Yeah, that's on the provider vacancy rate is 1.7. I know I don't have my financial book here in front of me, though, the budget that we're passing. I think there's 400 jobs in healthcare. Is that different, the 1.7%, or than the 400, I guess, that we're budgeting for? I know we budgeted for about the same last year amount of positions. So the vacancy rate number would be...
That 1.7% is providers only, and that is anybody that's a provider, which is nurse practitioners, PAs, dentists, physicians, surgeons. That's the whole gamut. And so now we've identified that the other issue that we have is nursing. So we've moved nursing over into recruitment, and we'll start reporting on those numbers. Because that's an area that we've identified that we need to spend some resources in recruiting those folks to come and work for us. Because that is a very competitive field right now, and there's a lot of other health systems that are incentivizing nurses, and they're starting to incentivize and pull nurses away from us. So we've got to look at how we can be competitive and keep nurses and recruit new nurses. We've already reached out and through one of our partnerships, we're helping to get some academic resources put toward the nursing school as it's moved from Connors and Northeastern have combined to create a transition so a nurse gets their education and moves up through their education. We are also supporting that and going to be bringing those nurses into our system to do their rotations. So hopefully that's going to be a good recruiting tool for us too, to get them in our system, get them established, and make this their home. So that's some of the things we're looking at, and that's some of the things that we've identified that we're working through to meet our needs as they continue to grow.
Okay. All right. Appreciate it, Doctor. Appreciate it, Mary.
Any other questions? Counselor Dobbins.
Sorry, Dr. Jones, could you describe the aerosol machines that we had to purchase, and then the number of total chairs that are in our clinics, which would translate into the total investment that we made in our dental clinics to do the very best we can to make the environment safe?
Yeah, so about 80% of the procedures we do in dentistry create an aerosol. There's not a whole lot of things that we do that don't create an aerosol. So in order to make it as safe as we can, and our dental clinics are very open. We have some closed rooms and some. The majority of our rooms are in an open environment, so it's easy for those aerosols to spread. So one of the things that we've done is we've purchased these that will sit beside each chair that actually have an umbilical that come out and if you will, hover above the mouth or when you're doing a procedure that will vacuum up any of the aerosols that are left that are not being evacuated out with the suction that's currently used in the mouth, as we've all had, when we've had a dental appointment. So we have about 122 chairs, I believe, 122 or 126, and those units were pretty expensive. They're about $1,500 a piece, and we used some of our CARES Act money to purchase those. But every chair has to have one. It takes and recycles. It filters that air, filters all the aerosols and all the stuff that's being put out into the air, out of the air, and then recirculates that air back into the room. So that's another part of our efficiencies that they're having to learn to work with. It's another piece of equipment that they're having to put up next to the patient and position position in a manner over the patient when they're working, and it's just part of adapting to the current environment that's causing us to have a little bit of a slower ramp up, because we have to make sure that we're doing all the things that we need to do to keep those machines, the filters changed out regularly, all the protocols go in place, how to use them, where they need to be positioned. So it has slowed us down a little bit, but it's the best way we know to keep everybody safe.
Thank you, Dr. Jones.
Anyone else with questions? Dr. Jones, I have a question. Are we experiencing a nursing shortage, or are we short of nurses because we're not fully staffed at capacity as of yet?
Well, we are experiencing some shortages in nursing, and some of it is due to, we have, and it's not just us, the whole state is experiencing a nursing shortage. There's more nurses retiring than coming out, and it's an aging population as far as the ones that even we have in our system. So when you look at that and you look at the currently the levels that we have working in the workforce that have not been sent home administratively, yes, we do have a shortage. And anytime we have someone gets quarantined or they're out at a birthday party, and there's a lot of nurses that are friends, and so you may get 2 or 3 that are at the same event, and then everybody gets quarantined, and that really hurts a specific department. And then we have to pull nurses from other departments to fill those gaps. And as you know, different nurses are qualified in different departments, so you can't just take a nurse out of primary care and stick them over in OB and expect them to function at a high capacity. There's a learning curve in each department, so we have identified that. We are working, and everybody's identified that. Other health systems offering incentives for nurses to transfer into their healthcare system. And so in order to be competitive, we're looking at what our strategies are and how we're going to be able to keep our workforce at a high level moving forward. So this is kind of things that are outside the box of Cherokee Nation. So whenever we come out and we say we need to start having a sign, this is an example, a sign-on bonus. If that's something that we move toward, that's a tool that other health systems are using. That's not something that we're set up to immediately be able to change tomorrow and say we're going to offer a sign-up bonus. We have to go through a process. We have to get that, those approvals. We have to make sure we have the money to pay for that. We have to make sure that all the HR needs are met and everybody's on board before we actually do that. So it's not something we can make a decision today and do it tomorrow. And we have to plan for those things. And that's the challenge that we have right now. So we have a lot of new nurses coming out that we do recruit and get into our system, but you can speak to this better than I can. An experienced nurse is far more valuable than a new nurse. However, those new nurses need to start training somewhere. So it's one of those things that we're working on every day, and we know there's a need, and it's a challenge and a strategy to move forward with it.
Very good. Dr. Jones, I realize that we are postponing a lot of elective surgery. Are we experiencing a bed shortage? And if so, how critical is that bed shortage?
I didn't catch you, cut out a little bit.
I'm aware that we're postponing some of our elective surgeries. And so my question is, are we experiencing a bed shortage to postpone even more elective surgery?
Well, yes and no. I mean, we have seen a increase in the number of beds that are being utilized inpatient, and so because of that, just to be cautious, we don't want to get into a situation where we're doing elective surgeries and then we don't have a bed to put someone in should they have some type of complication, or they need to be held over in the hospital for 2 or 3 days post-surgical for an elective procedure. Now, if it's an emergency procedure, we are not delaying those. But yes, we have seen an increase in bed capacity, and part of that bed capacity that we've seen increase is because of the use of remdesivir. Remdesivir is a drug that is used similar to what we would on the same. So when you have the flu, you're prescribed Tamiflu. Tamiflu helps to shorten the length of time that you have the flu. remdesivir is a drug that is being used for the same thing for COVID. However, it requires you to be in the hospital the whole time you receive the remdesivir. So if we have a patient that's a COVID patient, even though they may not require hospitalization, but they are going to receive remdesivir, we have to put them in the hospital and they have to be monitored in order to receive that drug. And we are a part of a study that allows us to administer that drug. So we have a number of our beds are being utilized for that. And so because of that, we have pulled back on elective surgeries in order to leave that bed capacity available for those patients that are experiencing COVID symptoms that would be on the border of whether or not they need to be in the hospital or not.
Dr. Jones, with school starting, I'm sure that we are going to anticipate some type of an increase in bed capacity for our school children to some degree. Well, do you all anticipate we will have enough beds locally if this should spike?
Well, we never know. We never know exactly what we're going to need. Obviously we're trying to alleviate the pressure off that as much as possible. And another thing that's putting a lot of pressure on our beds, and this is it's a phenomenon that's going along with this that you're starting to see a little bit of news pop up on is OB. We are going to have the biggest month we've ever had in OB. We are anticipating that we're going to deliver over 100 babies. We were at 91 at the beginning of this week for this month. So delivering babies also takes up beds, and it looks like we're going to get over 100 this month. There's anticipation that because of the COVID pandemic, that we're going to have a high number of babies born over the next 3 to 6 months, and that's a good problem to have, and that's a good thing that we want to make sure we have the capacity for those patients also. We do have the ability, if we reach capacity or we reach a point where we can transfer patients to our partner hospitals, and that has happened in the past, and we have done some of that, and we do that routinely depending on the acuity of care that's required, and in some cases it's a higher level than we can perform, so we transfer those patients out.
Very good. Are we going to have enough flu vaccine for our people, and when will the flu vaccine, when will we start the program?
So we've already started making plans. We have a work group that's working, and we'll be reaching out to you guys to let you know kind of our schedule for your communities. We've started putting together a schedule on how we're going to run our flu clinics. We've already started identifying what staffing we need, and we call it a doc in a box type deal where we have all the equipment we need to go out and start doing flu clinics in the communities. We're anticipating our shipments of flu vaccines should start hitting in by the second week of September, is what we're hearing. We've already put in for all that, and we've got the plans put together. So I know you're not going to be having community meetings like we have in the past where we've been able to do flu clinics. So what we're going to try to do is use some of the community buildings that are located in your different communities to come out and set up, do flu clinics, do COVID testing at the same time, similar to what you see in some of the drive-thrus where you have 2 lines, and we'll have 2 different areas where people can access us as we move out. We're also going to try to publish those schedules weekly so that the communities will know where we're going to be and when we're going to be there and what times we're going to be there. And we're going to reach out to you guys and hopefully have you guys reach out to your constituents when we're in your communities and help us to get as many people through those clinics as we possibly can.
Very good. Yes, Counselor Legg.
Hey, Dr. Jones, it's Darrell Legg. So currently our RN students that are receiving their RN license through Cherokee Nation has an agreement that they signed that they will do their precept at Hastings, and then if there is a position open that they have to work for 2 years to kind of pay back their tuition. Excuse me. Would this help if we got with Diane Kelly's group during Education Committee and maybe look at future and what we usually do is LPNs at the VOTEX, where they sign an agreement that since we pay for their tuition, they have to come back and work for us for the amount of years that they went to school. And as an example, an LPN goes for 1 year, so they would at least have to do 1 year buyback on their tuition. Anyway, other details can get worked out, but is that something that you'd be interested in? Because it would make sense for us to have to pay a sign-on bonus for a nurse, and then us have to also pay for their tuition when we can knock it out with just the tuition.
Yes, I'm a huge advocate of that. I've been advocating for that for quite some time. We have a lot of, our policies are very, very broad in what we allow employees at any time to, and we want to encourage employees to get to further their education, so they're allowed to turn in tuition that, in health, we allow it the equivalent of in-state tuition, and then they'll have a certain amount of time that they're allowed to get their degree. I've always, since I've been in this job, I've tried to advocate that we should have something coming back to us, because we're paying for that. So this is stuff that doesn't even go through the education of Diane Kelly's group. It goes through health as a policy that's been in place for years. And we see it every day where people will use us to get their education further, and then once they graduate with their degree, they move on. And unfortunately, we lose a lot of those employees without any kind of payback, so to speak, that comes back in, and we get a return on that investment. Now, does it help that Cherokee person? Of course it does. It helps them to increase it gives them the opportunity to increase their education and increase their lifestyle, which is a fantastic thing. I just feel like there's always been a little bit of a disconnect on that ability to have them utilize that skill that they've developed in our own system. We do have a directive studies program for dentistry and for medical providers that we pay their tuition, and they owe us a year for a year. So there is a precedent out there for that. I would like to see it extended and maybe even to nursing and some of those other areas. The nursing area you're talking about is an inpatient nursing program that requires them to come out and work inpatient in the hospital for a certain amount of time after they graduate. And there have been needs where we've seen that we've had a need in a clinic that's higher level than what we've had inpatient, and we've allowed them to fulfill that requirement out into one of the rural clinics. But that's something that we definitely have talked about. We just haven't moved forward on getting those controls in place to allow that to happen.
Okay, thank you.
Any other questions? Yes, Councilor Buzzard.
Yeah, Dr. John, just a comment of what I hear from some of my citizens out there. And I don't mean to be critical of our health system, because I think it's probably one of the best in the country. And I think you're doing an excellent job up there. But I've had a couple of people tell me that they went into our new clinics for things like that, and the provider comes in and just doesn't introduce themselves, doesn't say how you're doing, it just start immediately asking questions. I just wish it would be a little more friendlier. And I guess I say provider because that's what they told me. So I think probably that you could handle that as far as getting providers and all of our employees to be more courteous toward our patients and citizens. I know I've heard some complaints about the clinics, and I just hate to come to tell you about these complaints in committee, but I think, I don't know if the other council members get these things or not, but it just kind of, it upsets me when you have I'm going to say a pregnant lady that goes in there and they have a provider, and then that provider's gone one day and another provider comes in there to see her. Doesn't introduce himself at all, just comes in there and says, well, what's your problem? Why are you doing things like that? So I just want to have you to remind all your staff, and not only your staff, but the Cherokee Nation staff in general, about being courteous to our citizens, being courteous to our patients. I just think that's good. I know most council members are sitting here, gets those calls, gets those complaints, and they don't really want to come to the committee and say these things, and I just think it needs to be put out there that we get those calls. I get them. I just want to pass it on to you so you can pass it on to the people that work for us. The Cherokee Nation pays a good salary for those people, and we ask them to treat our citizens with respect. So just want to pass that on to you. Thank you for listening.
Yeah, and I'll address that real quick. Anybody that knows me or, has seen what we've done with the dental program, and that's something that's always been on the forefront of my priorities is customer service and how we treat our patients. That's part of why when we recruit, I always try to put an emphasis on trying to recruit people from communities that they'll be working in, so that we can have that accountability to their friends, family, their community members that they see in Walmart and what the grocery store and whatever. So that has always been a high priority. We try to emphasize that, through our supervisors. It doesn't always happen, and I hate to say it, but right now, and it's not an excuse, it's just a reality that our workforce is very taxed. We are working with people that are pulling lots of extra duties, extra hours because of our workforce being consolidated and being a little bit shorter than it would be if everybody was at work. We encourage people to take a step back. If if we see someone's getting a little too stressed, we try to help alleviate that and try to work on it. But right now, tempers are a little bit, people are stressed, and it goes both ways. The patients are stressed because of the anxiety that goes along with all the things that are going on. The staff is stressed because of the hours and the extra duties we're asking them to do, and to keep moving forward and trying to provide these services and keep all these service lines open, even with reduced staffing. Again, that's not an excuse. We should treat everyone with respect and dignity and the customer service. But currently, it's a different animal right now, and it's hard for us to go in and be, we can counsel and say this is how we prefer it to be done. We do a little bit of reinforced education. But it's hard to be too critical when people are going above and beyond right now, and they're really doing all they can to, again, keep all our service lines open. And we have been very fortunate to this point. Other than elective surgeries, we haven't cut back really anywhere that wasn't absolutely required by an accreditation board or by a governing board that oversaw it. So I feel like we're pretty fortunate in that area, and it's always a place that we can improve on, and it's one of our priorities that we talk about in leadership meetings all the time, making sure that we're watching, we're keeping an eye on those things, and we address those concerns when they're brought to our attention.
Well, thank you for that. And I know before, it's been several years ago, under a different administration, they had people that actually run around and analyze this. They run around and did those things just to see how patients were being treated and how they were being responded to. And I guess that's gone away because I haven't heard of that anymore. But I just think it's a good idea, and they can give you the feedback themselves, someone that you put out there to do those jobs. So, but anyway, I just want to tell you, that I'm proud of our health system, proud of our buildings and stuff like that. But I just think we can improve, and I'm sure, hope you've heard about the pandemic. It's put a lot of stress on a lot of people. But anyway, I think we're doing a good job. I think the telemedicine has taken a lot of the stress off, which is good. I like that too. So I just want to thank you for what you're doing there. But I just want to let you know, I get calls from our Cherokee citizens that use our clinics and hospitals and stuff like that. And that's some of the feedback I get back, and I just want to pass it on to you. Because coming from you in a memo, something like that could make all the difference in the world. So thank you.
And I will stress, we do still round. It's been a little bit changed a little bit from what we have done in the past, just simply because of the exposure and the COVID and how we have to do the PPE and stuff. And we do still round to our patients and providers. And then, so yes, that is something that we're still doing. You're just not seeing it as much as it was in the past because of the new protocols and how we have to keep people safe and separated. Moving forward. So hopefully we'll get back to some other sense of normalcy that allow us to be more interactive. We still have our are available at any time to any of our patients that have concern, and we try to have that engagement at all times. So
thank you, Dr. Young.
Any other questions for Dr. Jones? Dr. Jones, thank you for that outstanding report today, and please thank our health heroes for all their work in these difficult times. We appreciate them. I would like to inform council that George Velour was not with us today because he's in quarantine, and Tara Lee has offered to take him any questions that you may have to get answered for council. Is there any other old business? Any other new business? I'd like to announce that our next meeting is tentatively scheduled for Monday, September the 14th at 1 p.m. And with that, I take a motion to adjourn.
Second.
Second. All those in favor? Aye.